A very good evening to all of you. Myself, Dr. Hetal Kumar Vadera. I am a consultant anesthesiologist at Sterling Hospital, Rajkot. Uh, First of all, I will like to thank Academy of Regional Anesthesia India for giving me this opportunity to speak to all of you. I am going to talk about PNS guided infraclavicular block. This is a very important block. In the era of ultrasound guided blocks, PNS guided blocks looks like it is an inferior block or it is not that effective. But in India and in many countries, ultrasound is not available to all. Especially for freelancers, ultrasound is a distant dream. So PNS will be important. PNS technique will remain always important for freelancers and institutes where ultrasound is not available in operation theaters. So I am going to talk about PNS guided infraclavicular block. So if I talk briefly about anatomy, all of us know this is brachial plexus. If you look here, these are the roots, these are the trunks, here are the division, and if you go down there will be cords and then distal nerves like median, ulnar, radial or musculocutaneous nerves or other nerves. So if you look if you give a block at the level of trunks or at the level of roots, it becomes your interscalene block. It is used for shoulder surgeries. If you go further down, just above the clavicle, lateral to the subclavian artery, you will find divisions of the brachial plexus, and if you block at this level, it becomes your supraclavicular block. And this is important for surgeries of whole upper limb, and it is like a spinal of upper limb. So you can do any surgery with or I will say most of the surgery with supraclavicular block. If you go further down at the level of cords below clavicle, if you give the block, it becomes your infraclavicular block. There are different variants of infraclavicular block and you can do it at different levels. If you look at this anatomy image, this is basically of ultrasound guided costoclavicular approach of infraclavicular, where axillary artery, this is axillary artery, this is axillary vein, and these are the three cords lying lateral to the artery just below the clavicle. So at this level, VIB falls at the same level. So if you inject the drug at this level with single injection, you can block all three cords and you can have an excellent effect with low volume of the drug. If you go further laterally, just below the coracoid process, cords will take their anatomical positions, like lateral cord will remain lateral to the artery, posterior cord is posterior to the artery, and medial cord is medial to the artery between artery and vein. But it is not fixed. There are many anatomical variations. Sometimes posterior cord lies posterolaterally, medial cord lies posteromedially, lateral cord is at supralaterally, and sometimes at lateral cord is always most superficial. If you go deeper, you will find posterior cord, and medial cord is the deepest cord. So this is briefly about anatomy. There are many approaches. First, in 1917, Bézi described it. Then came the Babitsky approach. Then it suddenly disappeared from the practice. It was not even in the textbook of regional anesthesia. In 1973, Dr. Prithviraj, who is the I will say Bhishma Pitama of regional anesthesia, introduced it again into practice. He was going at the midpoint of clavicle. He was directing the needle toward axilla and stimulating the cords with the needle and giving the block. Then came the Whiffler's approach. It was basically giving larger volume, just like Pericoracoid approach, and he was giving it without PNS. But most popular technique are pericoracoid infraclavicular block and vertical infraclavicular block. So why we need infraclavicular block? We have supraclavicular block. If we want surgery in distal part. We have axillary block. With that, there are less chances of, if you compare it with a supraclavicular block, infraclavicular is with less chances of pneumothorax. There are less chances of phrenic nerve palsy. In fact, with pericoracoid approach, there are less chances, almost up to zero, of phrenic nerve palsy. With VIB, there are 25% chances of phrenic nerve palsy with higher volume. And it is a best approach for catheter placement, because it is a muscular area and catheter get fixed easily, and there is no movement in this area, so catheter remains there at the place, and you can give continuous block. If you compare with axillary block, in axillary block you require abduction, which is not required here. If you want to prevent tourniquet pain, it is difficult with axillary block, but if you give infraclavicular block, it is just like a supraclavicular block, it gives similar effect. Musculocutaneous nerve is not spared with infraclavicular block most of the time, which is paired with axillary block, and you cannot place a catheter in axillary area. So if we talk about VIB and pericoracoid block, this is the clavicle, this is the axillary artery, this is the axillary vein, and these are the three cords. So at the VIB level, or just below the clavicle, all three cords lie lateral to the artery. Superficial most is the lateral cord, then you find the posterior cord, and medial cord is the deeper most. But if you go a little distance away, if you go little laterally, then they will take their anatomical positions, like medial cord will go between the artery and vein, posterior cord will be posterior to the artery. So at the pericoracoid level, you will find these cords lying lateral to the artery. So if we talk about VIB, that is vertical infraclavicular block, anatomical landmark is first is jugular fossa or suprasternal notch. You have to palpate the suprasternal notch. Then you palpate the ventral apophysis of acromion. Draw a line joining it. Then go just inferior to the clavicle and insert the needle perpendicular to the skin. At this level, plexus lies superficial, so you require 5 centimeter needle. Usually you will find the plexus from 3 to 5 centimeters, so you don't require longer needles here. But there is a issue. There are difficulty in landmark identification. So how will you identify the landmark? Especially ventral epiphysis of clavicle is difficult to palpate. Jugular fossa is easy to identify, but sometimes you will palpate the coracoid process, or sometimes lateralmost part of the acromial process, or sometimes humeral head. So there is difficulty in identification landmark. So what will you do? You need a simple tactic. You have to go from behind. First palpate the spine of the scapula, go from midline, go laterally, palpate the lateralmost part of the acromion, and then go for ventral part of the acromion process. So palpate from medial to lateral, go anteriorly, and then palpate the ventral apophysis of acromial process. So this is how you can locate from behind. But there was an ultrasonographic study by Greher et al., who suggested a modified method for VIB. He showed that with 20 centimeter, if the distance between suprasternal notch and ventral apophysis of acromion is 20 centimeter, then it is an optimal length. If it is 22 centimeter, you can insert the needle at 11 centimeter and you will find the plexus. But if patient is shorter, length is less than 22 centimeter, then you require some modification. Then you have to move 0.2 centimeter laterally for each 1 centimeter below 22 centimeter. So suppose if it is 20 centimeter, you have to go 0.4 centimeter lateral to the midpoint. So mark a point at 10 centimeter, go 0.4 centimeter lateral to it, and you insert the needle. Otherwise, there are chances of pleural puncture, there are chances of vascular puncture. And if patient's height is longer length than 20 centimeter, then you have to move medially. 0.2 centimeter medial for each 1 centimeter above. But in Indian subcontinent, usually patients have length less than 22 centimeter. So correction for smaller patient, as I said, shift entry point of to 0.2 centimeter laterally for each centimeter of clavicle that measures less than 22 centimeter. So suppose if it is 18 centimeter, then 22 minus 18, that is 4 centimeter, multiplied by 0.2, that is 0.8 centimeter. So entry point should be shifted 0.8 centimeter lateral from the midpoint. So this is small correction for smaller patient, and if you do it, you will find the plexus easily. Second most important point, needle direction should be never medially. If you go medially, you will puncture the vessel. If you go medially, you will puncture the pleura, and chances of complication is higher. So never direct the needle medially. Always go perpendicular to the skin. If you don't find the response, go caudally or go cranially and look for the response. If you still don't find the response, look for the landmarks, again mark the landmarks, and if required, go more laterally rather than going medially. So here you can see I am doing the mistake. Here I am going medially. This is the lateral, this is the medial, and here you can see I am directing the needle medially. This should not be done, otherwise there are chances of complication. So never direct the needle medially. It is a wrong technique. When you insert the needle initially, what happens initially? You will find a response of pectoral muscle contraction. That is basically because of contraction of pectoral muscle, because of stimulation of lateral and medial pectoral nerve. So if you find that response, you don't need to inject the drug there, you need to go deeper to find the proper plexus. So this is fine. You find the pectoral muscle response, ignore it, go deeper, and you will find the response. Initially you will find the lateral cord response, that is the flexion of the first three fingers and opposition of the thumb. If you find this, you can inject the drug there, but chances of failure is high. So you have to go deeper, and you have to find the posterior cord response, that is the extension of the fingers. So you insert the needle and look for the extension response. If you find the extension response, then you can go for it. Here you can see I set the PNS at 1.1 milliamp. Don't go for 1.5 milliamp because it will cause a great jerks in the hand, which is painful for fracture patients. So if you find this response at 1.1 milliamp, reduce the current to 0.5. If you can, if a response is still there, you can inject the drug there. You require 20 ml of 0.5% bupivacaine or ropivacaine for surgical anesthesia. If you want to use for analgesia, then 0.2% ropivacaine or 0.25% bupivacaine is enough. So at 0.5 milliampere, if you find the response, inject the drug. But you reduce to 0.3. If you still find the response, then don't inject the drug, readjust the needle, and then only inject the drug. Here this is very interesting. This was the patient where I give VIB and scan in the supraclavicular area. Here you can see this is the subclavian artery, this is probably pleura, this is the first strip, and this is the plexus. And here you can see the drug is spreading proximally as well in the proximal area, that is supraclavicular area. So you can see the drug here. I scanned further upward. These are the scalene muscle, this is the interscalene area, and still you can find some drug there. So we will see that there are chances of 25% chances of phrenic nerve palsy with VIB if you inject higher volume. So this is how drug spread proximally in the plexus, and sometimes it causes phrenic nerve palsy. Second approach is pericoracoid approach. It is lateral approach, so less chances of phrenic nerve palsy, less chances of pneumothorax, but it is bit deeper. Here plexus go deeper, so you have to use larger needles, longer needles to find the plexus. Landmarks are simple. You have to palpate the coracoid process. If you cannot find the coracoid process, you put your fingers medial to the humeral head. Ask the patient to abduct and adduct the arm. Bone moving underneath your needle, underneath your finger is the coracoid process. So that is how you can palpate the coracoid process. Mark a point 2 centimeter medial and 2 centimeter inferior to it, and that is your entry point. So success rate is low with single nerve stimulation, better to perform multiple nerve injection, but when you inject the drug surrounding posterior cord, sometimes you don't get response for lateral cord and medial cord because drug is spreaded around lateral and medial cord as well. So sometimes it becomes difficult, but if you can stimulate all three cord, success rate is higher in literature. So here you can see I have marked the coracoid process. This is the clavicle, 0.2 centimeter medial and 2 centimeter inferior to it. I am inserting the needle and looking for the response. Here you can see this is the patient of AV fistula. I am inserting the needle perpendicular to the skin. I am going inside. I will like to see posterior cord response, but if I cannot find the posterior cord response, I can inject the drug with lateral cord or medial cord response also, but success rate is low. You can see I am locating the plexus. I can see some contraction. I am checking which response it is. You can see the flexion of the fingers, and that is probably because of the stimulation of the lateral cord. I am reducing the current, and here I am injecting the drug. So with that you can also inject the drug, but it is better to go for posterior cord response. This is the musculocutaneous nerve response. If you find this, never inject the drug. This is because of flexion at the level of elbow. Musculocutaneous now gets separated sometimes at the level of pericoracoid approach, and if you inject with this, your entire plexus will be spared and there won't be any effect. So with this response, never inject the drug. This is the most desirable response, that is the posterior cord response. So if you get the extension of the finger, then you can inject the drug and you will have an excellent effect of the block. You require 30 ml of 0.5% ropivacaine for surgical anesthesia or bupivacaine for surgical anesthesia, and 0.2% or ropivacaine or 0.25% bupivacaine for analgesia only. You can put a catheter here with posterior cord response, and you can continue 4 to 6 ml per hour 0.2% ropivacaine for surgical anesthesia, especially for surgeries of elbow or forearm. So if you compare VIB with pericoracoid, VIB is superficial, it is less painful. Pericoracoid, it is a deeper approach, it is more painful as you pass through the muscles, so you require some good local infiltration. VIB is single injection. For pericoracoid, it is recommended multiple injection. VIB you require 20 ml of LA, while with pericoracoid you require 30 to 35 ml of LA. With VIB, but with VIB there are higher chances of pneumothorax and phrenic nerve palsy, while with pericoracoid there are less chances of pneumothorax and phrenic nerve palsy, but it can happen if you are going for multiple injection. There are chances of pneumothorax with pericoracoid approach also. With VIB, less chances of vascular puncture because you are doing single puncture, but with pericoracoid there are higher chances because you are looking for multiple responses. VIB, as I said, require less volume, 20 ml is enough. For pericoracoid you require 30 to 35 ml of LA. Possible complication, as I said, with supra pneumothorax is 0.5 to 6%, but with VIB and pericoracoid it is 0.2 to 0.7%, so it is less as compared to supra. And phrenic nerve palsy with supra it is 50%, with vertical infraclavicular or VIB it is 25%, and with pericoracoid approach it is almost 0%. So complication rate is lower compared to supraclavicular block. Failure rate with if you can stimulate the posterior cord, failure rate is low, 5.8%, but with medial cord and lateral cord, failure rate is higher. So this is all about VIB and pericoracoid block. These are the simple blocks. You can do it with PNS, and you can have excellent analgesia with less chances of phrenic nerve palsy, and pneumothorax. Some of the beautiful animation is are prepared by Dr. Maulik Mehta. He is very good friend of mine, and he is practicing at Ahmedabad. He is a regional anesthesia enthusiastic. So I'm thankful to him for providing this beautiful animation. Thank you all of you for your attention. Thank you very much.